So it's now my pleasure to introduce our Vice Chair, Community and Partnerships, Dr. Melanie Henry, to introduce our Earl Dunn presenter.
So earlier on today, Jack, you made this comment about the idea of finding the similarity between your place and mine, and that really resonated for me. And I feel like that's a lot of the work that we do in family medicine. The Earl Dunn Lecture is an award that's named in Earl Dunn's memory, and it's to celebrate his work as one of the top pioneers in telemedicine and research in family medicine in Canada. Now, when I started thinking about this in terms of what the link is between the work that Naheed has done and telemedicine, initially I had some trouble and some struggles. But eventually it came back to linking the places and the people together. And I think that that's part of what we're going to hear about today. The honor of this award goes to a DFCM faculty whose research continues to advance primary care, and I can think of no better recipient than my colleague and friend from medical school, Dr. Naheed Dosani. As a palliative care physician and health justice advocate, Naheed is dedicated to advancing equitable access to healthcare for people experiencing structural vulnerabilities like poverty and homelessness. These efforts include founding and leading the Palliative Education and Care for the Homeless PEACH program at Inner City Health Associates in Toronto, serving as the medical director of Kensington Hospice at the Kensington Health, the health equity lead at Kensington Health as well, and as a health equity expert and advisor at the Canadian Partnership Against Cancer and as a palliative care physician at St. Michael's Hospital at Unity Health Toronto. Dr. Dosani shares his passion for palliative care and health equity with learners as an assistant professor of the Department of Family and Community Medicine here with us, and his research interests include health systems innovation, and addressing access to equity-oriented care for structurally vulnerable populations. Dr. Dosani has received many prestigious awards and honors, and I try not to think about us graduating at the same time as I say these things for you right now. They include the Meritorious Service Cross for Humanitarian from Canada's Governor General in 2018, a Humanitarian Award from the Canadian Society of Palliative Care Physicians in May 2019, and an Early Care Leader Award from the Canadian Medical Association in 2020. Most recently, Dr. Dosani received an honorary degree, Doctor of Laws, from the University of Tech University in 2022. So it is both my joy and delight to introduce and have Dr. Dosani come up.
Thanks for that great introduction, Mel. And as you all heard, Mel and I go way back to medical school. So funny story about Mel this morning. She found me in the hallway and said, "Hey, Naheed, I was so nervous about introducing the person who's going to give the Earl Dunn lecture this year. And then I found out it was just you. So I'm not so nervous anymore." Thanks, Mel. No, but seriously, I'm very grateful for that very kind introduction, and we go way back, so it's all cool. It's an honor and privilege to be a recipient of the 2024 Earl Dunn Award and to be able to deliver this lecture here today. My name is Naheed Dosani, and I'm here to talk to you about living and dying on the streets towards health justice through a palliative care approach. Today, I acknowledge that we are on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We are deeply grateful to have this opportunity to be on these lands to do this work. In terms of conflicts of interest, I do receive leadership honoraria from Inner City Health Associates, Kensington Health, and CPAC, and I'm a member of a speakers bureau called Talent Bureau. Today, I'm really excited to have a conversation with you all rooted within the principles of family medicine, where I'll aim to first highlight the impact that structural vulnerabilities like homelessness have on healthcare outcomes and the dire need for primary palliative care within our health systems. Number two, introduce innovative healthcare interventions, research, and advocacy efforts based in primary care that have aimed to address health inequities at end of life for unhoused people. And number three, reflect on our collective work in caring for those living and dying on the streets, share lessons learned for what matters most today and the future for the field of family medicine. For me, The journey really began the day that I met Terry. I was a first-year resident trainee training at the University of Toronto in family medicine when I was working at a local men's shelter, and I was tapped on the shoulder and asked to see a man who was in crisis. He was shaking, he was writhing, he was curled into a ball, and as I examined his mouth, I could see what was causing him so much distress. He had a tumor that had started at the base of his tongue, and it had spread throughout his head and neck. He had been on the streets for over a decade. He was a person who had schizophrenia. He was a person who used drugs. He was diagnosed with his cancer 1 year before at a local cancer center just down the road, and due to his mental illness, he was not able to follow up for care. As the tumor grew, he did what any one of us would do. He went hospital to hospital, ER to ER, walk-in clinic to walk-in clinic, seeking the kind of care, the kind of pain control that any person in this country, in this world, should have access to. Terry was denied access to medicines that would treat his quality of life. He just wanted something for his pain. Maybe it was the words he said. Maybe it was the words he didn't say. Maybe it was just straight up stigma, but he didn't get the care that he needed. And he found himself in our care that day at the shelter. I worked to build a relationship with him, trust, hopefully some rapport. He promised me he'd work with me the next day, so I got to work really early at the shelter the next day because I was so excited to support him and get him back on a better path with him and to help him along his journey. I couldn't find him in his room. I couldn't find him in the dining area of the shelter. And one of his friends called from down the hall and said, "Hey, Doc, are you looking for Terry?" And I said, "Yeah." He said, "Oh, you didn't hear? Terry died last night." Terry's body was found in the early hours of the morning by a commuter on her way to work. It was too little, too late. He had overdosed on a combination of alcohol and street drugs. It was too little, too late. He turned to the best pain relief that he knew. Terry's death changed my life forever. And you can't help but think how many others have died like Terry in our communities. I ask that today you think of who your Terry is. We all have at least one, and many of us have more. Someone that you knew, someone that you cared for, who died like this. I ask that you keep your version of your Terry front and center in your minds and in your hearts, because I carry Terry in mine every single day, and especially on this day with you. It goes without saying that in 2024, a room like this knows full well that the vast majority of what's making us sick, over 60% in our communities, is based on how we live, learn, work, and play, otherwise known as the social determinants. Yet, one thing that has always bothered me is that the health systems we work within are so comfortable talking about the fact that inequities in the social determinants of health exist, but are so uncomfortable talking about what drives inequities in the social determinants of health to begin with. The fact that these inequities are often presented as static inequities that cannot change or be modified, when in reality, if we only dug deep, we could actually identify these drivers and modify them. So let's dig deep. For those who can't see this in the back, depicted here is an apple tree designed by our colleague, Dr. Nanki Rai. The apples are the products of a good healthcare system, the kinds of metrics the WHO might track: life expectancy, neonatal mortality, access to mental health. So why is that some communities grow ripe and juicy apples and others don't? The answer lies at the roots of the tree, the structural determinants of health, which are driving inequities in the social determinants of health. Today, and through our conversations as we evolve and grow our primary care models, let's be sure to name these drivers: racism, capitalism, classism, ableism, xenophobia, transphobia, sexism, colonialism, and a whole host of factors we don't often talk about in mainstream healthcare discourse. We're here in this room because we have a responsibility to name these factors. We won't ever change inequities in the social determinants if we don't name these factors. Many of these factors are contributing to the fact that we continue to see social disparities like homelessness on the rise in Canada. For our country of about 35 million people, homelessness is impacting over 270,000 unique Canadians each year. Sleeping rough or unsheltered is up 100% coast to coast in Canada. Meanwhile, many regions are reporting a disproportionate representation of unhoused people among racialized and Indigenous peoples. The worrisome part is that this recent research that has come out shows that actually these counts could be as high as 3 times more due to rural, indigenous, and young people being missed from our typical counts. Also worrying is the impact that homelessness has on health. The raw reality is that being unhoused is by definition meaning that at some point you will deal with seriously ill health. Just as examples, people who experience homelessness are 28 times more likely to have hepatitis C, 5 times more likely to have heart disease, and 4 times more likely to have cancer. Average life expectancies for unhoused people, depending on the research you read, are very low. In Canada, we often cite research that has shown that life expectancies range from 34 to 47 years old. I'm going to say that again, 34 to 47 years old. Also, when surveyed, the vast majority, over 90% of housed people in Canada, say they want to die at home if given the chance. Our experience shows us that the vast majority of unhoused people actually just want the same thing. But they don't die at home in their shelters, respites, and drop-ins, the places that they do call home. They die in hospitals and emergency departments, and sometimes the park or a park bench, because we've literally designed a home healthcare system that is structurally unable to deliver care, palliative care, for people without homes. And the results are devastating. What does the data tell us? It tells us that homelessness cuts a person's lifespan by 50%. When you take into account all of the data points, literally, the social diagnosis of homelessness cuts a person's lifespan by half. And so clearly, homelessness is a life-limiting illness. Clearly, homelessness is a terminal diagnosis of the social determinants of health. As many of you know, truly, there is no better time to look at how a society treats its most vulnerable than when they die. Our experience shows us that as people who are unhoused get closer to end of life, inequities accumulate, the gap widens. We are talking about people who are both in need of palliative care services and experiencing deficits in the social determinants of health, and as a consequence, live with complex, interacting health and social concerns. As an inner-city nurse once said, who was a participant in our equity-informed research so poignantly, she said, and I quote, "It's a time. At the end of your life, when I think it brings into view the things that are there and the things that aren't, the haves and the have-nots become really amplified," end quote. This double vulnerability brings home the point that death is most certainly a social justice issue and a health justice issue. So in 2014, my colleagues at the Inner City Health Associates in Toronto decided to make a change. We knew we had to do better to meet the palliative care needs of unhoused people. We knew that we needed a model that was built off the best practices already developed in many of our homeless health systems: the need for high-quality primary care, mental health care, outreach-based care, a focus on case management, interprofessional approaches to care, care across settings, leading with lived experiences, and integration within the housing sector. At the same time, we recognize that the concept of integrated palliative approaches to primary care was missing from many of our homeless health delivery systems here in Toronto, but also around the world. And so, on July 1, 2014, the PEACH program, Palliative, Education, and Care for the Homeless, was born as Canada's first mobile, street, and shelter-based palliative care program, aiming to provide health care to unhoused people with serious life-limiting illnesses, so that no person would die alone or fall through the cracks, whether on the streets, in a shelter, or under a bridge. The program started out the back of my Honda Civic 1 day a week, no joke, very true story, with my colleague, Nurse Namareg Ahmed, and I driving around the streets. And fast forward to 2024, the PEACH program has grown to become the largest community-based palliative care program for people experiencing homelessness in the world. Rooted in family medicine and primary care, our team today features 7 passionate family physicians, a nurse coordinator, home care coordinator, social work health navigator, a peer worker, a PEACH psychiatrist, and an interprofessional roster of home care professionals that work in non-traditional home settings. The program is made possible through a unique partnership between Inner City Health Associates, Kensington Health, and Toronto Central Home and Community Care Support Services. As a result of this partnership, we have cared for over 1,000 people since our birth and carry between 110 and 140 patients on our caseload who are living and dying on the streets at any given time across the City of Toronto through a 24/7 model of care. In 2018, the PEACH program was named as a best practice by the Government of Canada in Health Canada's palliative care delivery framework. In 2019, the University of Toronto, DFCM, named PEACH an emerging practice in health equity and social accountability, and has since created formal partnerships where palliative care and global health enhanced skills residents rotate with us as part of a core learning experience. And finally, the PEACH program has also been recognized and honored by Canada's Governor General as a trailblazing practice in palliative care. Over the past 10 years, our mobile PEACH program has really leaned into caring for those who often fall through the cracks in our society, with 60% of PEACH clients having at least one mental health diagnosis and 60% also being people who use drugs. Meanwhile, a growing proportion are uninsured people who are refugees and asylum seekers. Is PEACH effective? Well, a one-year retrospective chart review of our care showed that 64% never went to the hospital, 80% died exactly where they wanted to, and 83% were reconnected to family and friends. But really, PEACH works because of our commitment to core values. Harm reduction. Yes, we prescribe opioids and other controlled substances to people who use drugs. Trauma-informed care. We care for many people who shouldn't be dying, but are dying because healthcare has traumatized them, and that's why they didn't access healthcare to begin with. An anti-oppressive approach to care. We're not here to top-down deliver healthcare resources. We're here to redistribute health resources in a justice-oriented way, and an interprofessional approach to care. We don't negotiate on these values and never have since our program's birth. In keeping with the spirits of family medicine, our PEACH team strives to be rooted in the communities we serve and go beyond the domains of clinical medicine. We educate the next generation, like many of you, through formal partnerships with health training programs like the DFCM. We advocate for a healthy end to homelessness. We can conduct advocacy-based research to raise the bar and give this work the credibility it deserves. And finally, like many of you, we are social prescribers. It isn't good enough to treat the pain, the nausea, and the constipation. We prescribe housing, we prescribe income, and assist with many things like healthcare navigation, and even arrange transportation for people to get to their appointments. Today, I'm reflecting and remembering many of the people that our PEACH team has cared for over the years. Pandora was a young, energetic, creative, and charismatic woman in her 20s who faced physical and sexual violence while growing up due to a family member. She ended up on the streets where she fell into a life of drugs. Unfortunately, she was diagnosed with infectious endocarditis and ended up in a large surgery center where she was denied access to potentially life-extending heart valve surgery because she was a person who used drugs, even though there was no evidence that people who use drugs fare poorer with that surgery. Pandora was discharged to the street without oxygen to breathe, medications to treat her pain, and without a stable roof over her head. Our PEACH team met her, built a relationship, and even at her request to lead with lived experience, worked with the CBC to help produce a documentary on her story on the CBC's The National. Tragically, 4 days into filming this documentary, Pandora died of an opioid overdose death. The documentary's direction changed into one that focused on the ripple effect that her death had on our PEACH team and her street family. I often reflect on the fact that I feel that stigma ultimately is what was the cause of death for Pandora. Pandora is a constant reminder that the stigma our patients face by the mainstream health system is not a frivolous matter. It's a matter of life and death. Archie was an elderly man who fell into homelessness for the first time at the age of 67. He was a homeowner, an engineer, and due to an unfortunate sequence of events, became homeless. One day, he was at a bus stop and started to have abdominal pain and vomiting. He was rushed to a hospital where he was diagnosed with terminal cholangiocarcinoma. He was discharged to a local men's shelter where our PEACH team got to meet him and care for him until end of life. His only last wish was to die in the place that he now called home, the shelter he was in, where he was a participant in a managed alcohol program. He said, "If you really want to care for me, then meet me where I'm at. I've lived a very traumatic life. I've found peace at this shelter. Let me die in peace at my new home." And so our Peach team did just that, did everything we could to provide the care there for him, trained shelter staff to support end-of-life care, brought in extra home care supports, and even conducted our medical visits with Archie's consent in the park in Allen Gardens, for those who know it, where he loved to do the daily crossword, so he could spend the time he had left doing the things that he loved. Archie died in his new home, the shelter, I suspect, with the peace he desired. We must always remember to acknowledge the full dignity of each person beyond the stigma of their marginalization. In truth, the Peach program works probably for 5 reasons. The first, we strive to integrate health and social services in every way. Number 2, we bring a trauma-informed approach to palliative care. Number 3, we see harm reduction as a core part of primary care and palliative care because it's a human right. Number 4, we're flexible and agile to meet people where they're at outside of hospitals and clinics. And finally, we start our days working from a place where we recognize that the system isn't broken, it was literally built this way. The healthcare system was never designed to care for people experiencing homelessness. Framing is everything. You know, the best part of the journey hasn't just been what we've done in Toronto. It's the part that the most exciting part has been the fact that we're part of a societal change that has happened outside of Toronto too. We're proud to say that we're now part of a family that is now an national and international family of teams and programs who've created Peach-like models in many communities through the lens of primary care and family medicine. On this slide, I note 2 of our sibling programs, the CAMP program, Calgary Allied Mobile Palliative Program in Calgary, Alberta, created by Dr. Simon Colgan and nurse Rachel Edwards, and the Port Palliative Outreach Team program in Victoria, British Columbia, created by Dr. Fraser Black and Dr. Kelly Sajdahar. Internationally, we've seen colleagues create mobile programs like Peach in Seattle, Portland, San Francisco, Australia, and even in the UK. In addition, our pan-Canadian research collaborative of mobile palliative care teams caring for structurally vulnerable populations, including teams based at the University of Alberta, University of Victoria, University of Calgary, Lakehead University, and of course, here at U of T, has produced dozens of publications via a decade of research and scholarly evidence in the area of equity-oriented approaches to palliative care. So what have we learned through this work? Well, when we closely followed structurally vulnerable populations who were living and dying on the streets through ethnographic research, we learned that, honestly, people living and dying on the streets are focused on survival, and palliative care is often seen as a luxury, or bells and whistles, or something that people don't even feel they deserve. We learned that many of our health systems say we don't see many people like this and don't know how to adjust their care approaches. We saw that basically palliative care and through a primary care lens is not often designed to meet the needs of people experiencing homelessness, and that as an unhoused person living and dying on the streets, you gotta go here for your social assistance, here for your food supports, here for your housing, silos, 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 see a lot of nodding, and there's not a lot of integration in that kind of care. We've also learned when talking to people who experience structural vulnerability, who are dealing with serious illnesses, that healthcare services, including palliative care, is not a safe or welcoming environment. We looked into the ways hospitals are built, clinics are built, the paint colors on the wall, the feel in a waiting room, and what people actually told us through participatory and ethnographic research is they don't feel welcome. It re-traumatizes people, and people just don't feel safe. When we spoke to informal caregivers, so the street family that often rallies around a marginalized member of the community, this could be a street brother or a street sister living in a shelter or in a respite, for example, we learned that there's great resilience there. There's a family. There's actually people who come together and support the caregiving experience. But what we learn is that caregiving in the context of inequities is a whole different ballgame than the kind of caregiving we typically talk about in our mainstream healthcare systems. Many of the street family who serve as informal caregivers are very sick themselves, and they're actually dealing with health inequities themselves. When we spoke to health workers about what it's like to provide palliative care for unhoused people in multiple cities, and the social care workers who work in the homelessness sector, we learned that people really love this work. They see it as important. They see it as a huge gap in the system, but we saw that there is immense grief among health and social care workers who often become the de facto families for these people if they don't have other street family. And this grief is often unrecognized, invisible, and yet profound. And finally, when taking a deep dive into the person-centered experiences of what it's like to access health and social systems at end of life, we learned that this whole thing where you get to choose where you get to die is actually not that true. There's a rhetoric out there about choice of place at end of life that typically people from higher socioeconomic status get to enjoy. If you're poorer, you're unfortunately constrained by various factors, which means you probably don't get to choose where you get to die or how you get to die. And this is just the beginning of a collective scholarly journey that we continue on to get at the roots of inequality, inequity at end of life, a time where, as a society, we should probably be getting the humanity part of end of life right. The reality is that after a decade of caring for people living on the streets and in shelters, our teams learned a lot. And so it begs the question, as family doctors who care for communities, from cradle to grave, with a holistic approach in mind, what can we take away from this work? So today, I humbly offer 5 lessons from our work in family medicine and palliative care to collectively challenge this community, our community, about what matters most today and in the future for the field of family medicine. And here it is. Number 1, our work is the advocacy. As a PEACH provider, there's no doubt that we sit downstream in the life trajectory. But there is no greater time to better understand how structural inequities lead to poor health and eventually death than being downstream to see it. Tragically, we at PEACH often are providing palliative care for people who shouldn't be dying and would not be dying if they weren't having to deal with poverty, homelessness, systemic racism, discrimination, and oppression. As family doctors, it's worth repeating that your advocacy, our advocacy, upstream is important. It will save lives. It's our duty within family medicine to advocate for increased social assistance rates, for food security, for improved access to pharmacare, dental care, publicly funded home care, and as part of the broader movement to end homelessness for good. While I know so many of us focus on our one-on-one care that we provide each and every day, the big picture work we do is important too. And while so many think that advocacy will lead to burnout, we've found that advocacy, in whatever form you choose, has been a potent antidote to burnout and moral injury. Sure, providing healthcare is what's needed right now in our communities, but we must see ourselves as part of the larger social justice movements around us. Some key questions that I ask of us all today. How are we using our credibility as family physicians to improve systems of care for the people we care for? To shape public policy? To get people to value dignity of life for an often stigmatized population? How are we using our privilege to elevate the issues and experiences impacting unhoused people, the people we care for who are often overlooked and silenced? How can we change that narrative? We can be leaders in this. In family medicine, we are leaders in this. We must see this as our mission, advocacy as the mission. An example of this advocacy as family doctors, we must challenge the mainstream health systems that our patients interact with, because if we don't, they will face systemic racism. Never forget the story of Brian Sinclair, a middle-aged Indigenous man from Winnipeg, Manitoba, who in 2008 presented to an emergency department for care. Over a 34-hour period, he was left untreated and ultimately died, probably from a UTI. His death sparked an uproar across Canada and even led to a book being written about the whole tragedy called Structures of Indifference, as a classic example of what systemic racism looks like. Never forget the story of Joyce Echequan, who was a woman who was literally dying in a Quebec hospital. And as she was dying, her health workers literally threw racial epithets and slurs at her as an Indigenous woman. She turned on her Facebook Live to record it all. She died. And the only reason we talk about her today is probably because she turned her Facebook Live on. How many others have suffered like Joyce who weren't able to turn their cameras on, and how many have suffered due to not just overt racism, but covert racism too. We have a responsibility to advocate for a health system where we go from cultural safety to anti-racism. We must challenge the cities and governments that continue to oppress and discriminate people experiencing homelessness around the world, but here in Toronto, in encampments. Toronto, like many cities across Canada, has seen a violent and significant uptick in state-led homeless encampment clearings over the past few years. These photos, which have now gone viral worldwide, because of how gruesome they are very real depictions of the state-led violence that has been sanctioned by our City of Toronto City Council over the past few years in response to homeless encampments. In fact, the City of Toronto has spent millions of dollars on policing and enforcement to violently displace unhoused people. So basically, encampment residents live in a city where they're not provided safe spaces to live, and then are violently being displaced and punished because they do not have a safe space to live. So basically, they've got money to displace people, but not to house people? Come on. We must speak out against the inhumane, involuntary displacement of people who experience unsheltered homelessness. We must push back, not just because it's the right thing to do, but because clinical evidence shows that this is an ineffective approach. This study, published in 2023 in JAMA, shows that encampment suites, bans, move-along orders, and cleanups that forcibly relocate individuals away from essential services will lead to substantial increases in overdose deaths, hospitalizations, and life-threatening infections, plus many more detrimental impacts. Devastating impacts, including a 151% increase in overdose mortality and significant increase in hospitalizations. We have a responsibility to speak out about the harms of involuntary displacement. Our voice is vital. Number two, we must empower and resource models of care that center the needs of people with lived experiences of structural vulnerability. Because we are so rooted in community, family medicine is perfectly positioned to listen, adapt, and respond to the needs of community by creating and innovating our models of care to best support people with lived experiences of structural vulnerability. I want to shout out colleagues at St. Michael's Hospital, at the family health team, who've done this by integrating a new role, an income health promoter, onto the team to work with low-income folks and helped lift them out of poverty. It's this kind of innovation that we must lean into if we want to provide equity-oriented care for structurally vulnerable populations. I want to introduce you to Michelle Clements. Our Peach team has been working to do this kind of work with Michelle for the past few years by creating new roles, including the role of a Peach peer worker. Michelle is our Peach peer worker. She's been hired to the team because of her expertise in lived experiences of homelessness. Michelle works with Peach clients across the city to build rapport, trust, and relationships, to provide support via companionship, connecting, and meaning. Why aren't peer workers more commonplace in our primary care and our healthcare systems? We've also designed a new social work role called the Peach Health Navigator. Depicted here is Selena Dyke, our Peach Health Navigator, who works hard day in and day out to address social issues facing our Peach clients. She finds housing, optimizes income, and addresses food security, all the while providing care through a trauma-informed approach. Our 2023 publication in palliative medicine was the first description of a role like this in community-based palliative care, and we certainly think that this kind of role should be more common to best support the needs of structurally vulnerable people. As writer and transformative activist Adrienne Marie Brown says, "Move at the speed of trust. Focus on critical connections more than critical mass. Build resilience by building relationship. Less prep, more presence. Prioritize trust and respect above any other goal. We will never have equitable healthcare if we don't move at the speed of trust with the communities we aim to care for." Number three, we must build capacity on social accountability through our educational offerings. There is a growing call for physicians as advocates and for medical education to be more socially accountable. Yet, there is emerging evidence that trainees feel their educational needs are not necessarily being met when it comes to advocacy and social accountability. At Peach, we have offered our rotation, Palliative Care in the Inner City, integrating social accountability and palliative care, since 2019. Developed with the goal of integrating clinical palliative care for structurally vulnerable people with social accountability, the rotation not only offers exposure to the clinical care that Peach provides, obviously, but also asks learners to complete a social accountability workbook where they reflect on selected readings and their experiences. Our Peach rotation has a 2-year wait list. It's very popular, probably because the experience is meaningful, but there aren't a lot of offerings like it. We need more, and we need to create more of these opportunities in family medicine that can emphasize the importance of equity-oriented care, comprehensive family medicine, shared care models at end of life, and cradle-to-grave care for a lifetime. The Avocado Framework on Social Accountability, depicted on this slide, designed by colleagues Dr. Ryan Miley, Dr. Robert Woolard, Dr. Sandy Buckman, and Dr. Rithika Goel, and Canadian Family Physician in 2016, still rings true today and is a great reminder of the ways that we can all be socially accountable in family medicine at the micro, meso, and macro levels. For those who are interested in learning more, I encourage you all to read this new report from CAMH called A Framework for Integrating Structural Competency into Physician Leadership Curricula by Ajik et al., and some of the co-authors are actually in this room as well. The authors of this report offer 9 enabling competencies required to achieve structural competency, because when physician leaders have structural competency and agency, they can act in ways to transform medicine and to prevent and reduce health inequities. Physician leaders need to build structural competency into all aspects of their work, including patient care, administration, education, research, and beyond. It's definitely a worthwhile read. And number 4, we must go from talking about improving equity to actually improving equity through real-world outcomes. Listen, it's been a decade of doing this work, and what we've seen in doing this work is there can often be a lot of rhetoric, a lot of buzzwords, and a lot of talk when it comes to equity. Lip service is not the goal, action is the goal. As a family medicine community, what are the real-world measurement outcomes we are striving for to show that we are delivering more equitable care? And what metrics and infrastructure are we going to use to show that we are actually doing this? While we are well positioned to do health equity work, we must strive for rigor when doing health equity work. Drawing on another example close to home, my colleagues at St. Michael's Hospital and the Family Health Team have also developed a brilliant health equity questionnaire that is a really good example of this. The St. Mike's Health Equity Questionnaire collects social determinants data in a patient-centered way, providing real-time feedback to patients on relevant resources and for providers to consider during their one-on-one care. In my new role as medical director at Kensington Hospice, Toronto's largest hospice based in the Kensington Market area, in just 1 year, we've gone from a hospice that serves structurally vulnerable people less than 5% of the time to a hospice that's now serving structurally vulnerable people 50% of the time. How? By implementing a new program called Radical Love, Equity-Oriented Hospice Palliative Care at Kensington Hospice. What is Radical Love? Well, it's a lot of things, including a new admissions process that triages not just medical diagnosis, but also social issues, by implementing new health equity training for all staff, and forming partnerships with homeless health providers in the community. But mostly it's a culture change where our hospice now foundationally operates around the concept of equity and a commitment to measuring targets around equity so that we're actually acting on what we're saying. We're not just talking the talk, we're walking it too. Local lessons have achieved national results too. I'm honored to serve as the co-chair of a $2 million initiative funded by Health Canada and delivered by Healthcare Excellence Canada and the Canadian Partnership Against Cancer, called the Improving Equity and Access to Palliative Care Collaborative, IEAPC. IEAPC is supporting and funding 23 projects in communities coast to coast across Canada over 5 years to improve care experiences, access to care, and health outcomes for people experiencing homelessness who need palliative care. 10 projects are already well underway through our Cohort 1 program, and we've just started our Cohort 2 program, which features 13 projects funded until 2026. Whether it's building out mobile models of care or bed-based and hospice models of care, these 23 IEAPC projects are working to ensure care is delivered in a safe and timely way, reducing ED visits and hospitalizations, and allowing people to receive care with dignity in the environments that they choose. IEAPC is also a good example of how government funding can serve as a catalyst for change around equity and sustainable change too. And number 5, maybe it's the palliative care in me, but to push this movement forward, we're going to need to care for each other better. And that will mean we'll need to grieve together. As I look out today at all of you, I cannot imagine the challenges you see day in and day out. We literally work in systems that do not care for the most vulnerable people we serve. And so we abut against system failures all day long just to care for them. From the primary care crisis to long wait times to administrative burden, there's a lot that's on our plates right now. What does this create? A perfect recipe for moral injury, compassion fatigue, and burnout. This work is not easy. This work stays with you. These experiences stay with you. What kind of trauma responses does this create for all of us? To push this movement forward, we're going to have to spend more time and resources in inspiring wellness in us. It is something I spend a lot of time thinking about with my Peach team, naturally, because we work in palliative care, but because health and social care workers working in the homelessness sector don't get enough support around grief and bereavement. Whether in the death or tragic moments that we see, how do we as family medicine serve as leaders in our community to build resilience on the teams that we work with? People think that grief slowly gets smaller with time. In reality, grief stays the same size, but slowly life begins to grow bigger around it. That's why since the birth of the Peach program, we've held grief circles to support the health and social care workers who do this hard work. You see, whenever a Peach client dies, we descend on that site. We form a circle, we light a candle, we hold a minute of silence, and then we cry together, and then we laugh together. We remember what it was like to care for the person. We reflect on what it was like to care for them. And then we think about ways that we can renew and reinvest in each other. We hold another minute of silence. We blow that candle out and leave that grief circle, knowing, sadly, we'll be back to do it soon again. Grief circles have become central to the culture of our compassionate Peach community. They've allowed workers to feel, to grieve, to express their pain, and to do it in places that feel safe. As I reflect on our Peach grief circles, I wonder, why isn't this more the norm in our healthcare systems, or even just generally across our health systems? While I know that grief circles are just scratching the surface of grief in our local community, they're starting a culture of change we need in healthcare. To support each other, we're going to need to care for each other. It's also why since 2014, we've also offered the Good Wishes program, a psychosocial intervention that provides special gifts for terminally ill patients cared for by Peach. It's anything from tickets to a hockey game or a Blue Jays game to a nice dinner, or in Richard's case, an unhoused man depicted here who was cared for by Peach and was dying of lymphoma, some art supplies so he could do the things he loved most, soap sculpting. For our Peach clinicians, the Good Wishes Project has been a potent antidote to moral injury and burnout because it allows health workers to address the total pain and suffering they are seeing in a meaningful way. In summary, here are the 5 lessons that palliative care for unhoused people can teach us about what matters most today and in the future for family medicine. Number 1, our work is the advocacy. Number 2, we must empower and resource models of care that center the needs of people with lived experiences. Number 3, we must build capacity on advocacy and social accountability through our educational offerings. Number 4, we must go from talking about improving equity to actually improving equity. And number 5, to push this movement forward, we're going to need to care for each other and even grieve together. As I close out, I reflect on a decade of work through the Peach program and our collective work across Canada and around the world. I reflect on the fact that this work is about trauma-informed care, which especially means that we have a duty to stay humble, give people choice, relinquish power, make people feel safe, and center our care around compassion. It's about meeting people where they're at, not just physically in shelters, alleyways, parks, and non-traditional health settings, but also emotionally, physically, and spiritually. It's about centering on our values, like harm reduction for people who use drugs, and not wavering from these values that are based in human rights, values that are rooted in justice. It's about raising the bar through commitment and rigor, with metrics, through collaboration and partnership, sometimes even with government, whatever we need to do to find the solutions we need in these desperate times. To move from equality-based healthcare, where people get the same things to be happy and healthy, to equity-based healthcare, where people get what they need to be happy and healthy, to justice-based healthcare, where people get the resources they want and where barriers are removed, so people can choose what makes them happy and healthy. It's about compassion, and hopefully with what we've seen today, that a palliative approach to care aligns well within our work as family doctors, and that it can heal through justice in our communities, and that it can mean the world to people at the same time. I hope that a palliative care approach through a health justice approach can inspire hope at times of hopelessness, can empower us at times of scarce resources, and can lift us up in times of deep loss, trauma, and grief. In conclusion, I want to thank you all so much for having me today. My deep gratitude goes out to Dr. Melanie Henry, Dr. Allison Mirbaum, Dr. Daniel Martin, and the entire DFCM organizing committee, and to each and every one of you who do this work each and every day and work very hard doing it. Thank you to the many organizations that support my work, Unity Health, University of Toronto, ICHA, Kensington Health, and CPAC. I feel very lucky to be part of these organizations. And finally, I told myself if I didn't nail this keynote, I'd have this really cute slide of my daughter, Nia, on the left, and this lovely photo of my wife with Nia, and Nadia, if you just want to wave, who came to watch me today. I felt this slide would probably make me feel a lot better at the end. So there you go. Thank you again. Thank you.